Welcome to Migraine Awareness Month. With us today is Roger O'Toole, Director and Headache Consultant at the Melbourne Headache Centre. How are you today?
I'm well, thanks, Sarah. Thanks for inviting me.
No problem. We're very excited to have you.
I'm excited to be here.
I think we'll just get stuck straight into the nitty-gritty of our questions because what you do is super interesting, and I think a lot of our audience are very keen to hear about it. So originally, you were into physiotherapy, but your clinic has now evolved from that. Is that correct?
Yeah, that's right. So I started as a general practitioner for probably about 10 years and started to adopt the techniques that we now use within that practice. But I found myself pretty quickly getting to work and looking through the diary for my headache patients rather than my other ones. So something was starting to sort of change.
Right. And when you say breaking away from that traditional sense of physiotherapy, what do you mean by that?
The traditional model of physiotherapy in headache in particular is really focused on, I guess it's a stretch and strengthen approach. You know, it's looking for, is there a movement disorder? And physiotherapy is very much about treating, you know, movement disorders in a sense. And what I was seeing is that most of the people that we see don't actually have movement dysfunction as such, but they do have issues in their neck. It's just they're not waking up with a stiff neck that they can't turn.
Sure.
And really painful, and it happens to be causing a headache. That's sort of bread and butter for that sort of standard manual therapy approach.
Mm-hmm.
What we're sort of now treating is much more the sensitivity rather than the mechanics.
Okay, excellent. So what types of migraine do you see in your practice?
Everything and stuff that I never even knew existed 10 or 12 years ago.
Mm-hmm.
So everything from, I guess, your bread and butter migraine types to, migraine with aura. But about probably 30% of the people that we see would have chronic daily symptoms. Now, whether that's sort of a classic migraine with headache, or whether it's more maybe a vestibular migraine where maybe only half of those actually have a headache, so it's almost a non-headache migraine in some respects. But a lot of those will actually have, so about 50% of those vestibular migraineurs have daily symptoms in between that wouldn't sort of fit a migraine classification so much, but they're dizzy with head movement, or they've got visual disturbance, things like that.
That's a really good point that you brought up before, that not all people with migraine have that headache.
Yeah, and one of the other things that, again, I'd never heard of until I was in the clinic was something like cyclic vomiting syndrome, which is considered a migraine subtype.
Mm-hmm.
But again, they have sensitivity to light and sound, and they have
a lot of overlapping.
The triggers, so all the triggers are sort of similar, and they have this periodic sort of episode, but not necessarily a headache. Yeah.
Okay, so tell me, if I wanted to come and see you, do I need a referral from my GP to make that happen?
No, you don't. So we take bookings directly, but we don't just automatically book everybody. So it's an interesting space. Headache can be quite challenging, so we actually speak to everybody before we book them. So we don't have actually an online booking system. We'll talk to everyone. It's important to us that we make sure that you're a good fit for what we do. So we want to get a little bit of an understanding about what's happening, but particularly probably more so with people that are having a fairly new presentation, or that their presentation has really changed quite dramatically. It's always important for us to work back through their doctor, or make sure they've at least had that sort of seen to before we will actually see them.
That's actually fantastic, because it means that you're part of a care team, communicating amongst other professionals in the field, making sure that every angle is covered. I think that that's a really great approach, being so personable and making sure that you're a good fit for them and they're a good fit for you. I think that's a fantastic way to do things.
Well, we understand that not everyone has the neck as a part of their problem, and migraine is a complex problem. We picture it a bit like a jigsaw puzzle at times, that
absolutely
all of the pieces in most people are sort of the same, but the pieces are all different sizes. So for one person, there might be a mild hormonal element, but it's not a big part of the picture. Whereas for someone else, that could be really dramatic.
Absolutely.
For others, their diet might be really critical, but for others, not so much. So we understand that the neck is the same. For some people, it is absolutely critical, and if we don't address it in the right way, they're not going to have a good result. But for others, and even people that do have significant neck pain at times, the neck, it sounds strange, but the neck isn't necessarily the main source of their issues.
Yes, absolutely. Absolutely. So upon reading your website, you mention in there that the aim for your team is to have patients become self-managed. So what does that actually mean, to be self-managed?
Yeah, so we have and this is the beauty of the approach that we use, the Watson headache approach. It really gives a great framework to sort of work through in terms of taking someone from that may not even have neck symptoms, but to be able to understand and tease out what the role of the neck is. So that initial consultation, that assessment, we're really looking for sort of 3 core factors. Whether there is a small fault in the top of the neck that we can change, so can we correct it? But in some people, this fault is a bit like having flat feet. A lot of people have got flat feet, but don't necessarily have shin splints or hip pain or knee pain from it. So do we actually need to treat it? So the third part of that, the really core part, is whether or not the neck is relevant. And can we see that by correcting the fault and symptoms ease? Or can we actually see that by connecting the dots? In other words, can we actually reproduce or mimic your typical headache? So can I push on your neck and you say, yep, okay, I can feel that behind my eye. That's where I get my migraine. So we're not triggering a migraine as such, but literally just sort of connecting the networks. So if we can see that, we expect to see significant change within 2 weeks.
Right.
That sounds incredible.
Yeah, it does.
To me, initially it sounded ridiculous, but it almost doesn't matter how long the symptoms have been there. So we'll talk in a little bit about the case study research that we've been doing. But one of those patients she was in her mid-40s, and she'd had migraines since she was a teenager, and pretty much every day of her life. And they changed just as quickly as the other 2, and one had had it for 3 years and the other was 18 months. So
interesting.
When we can make changes there, and when it's connected, it's very potent and produce quite dramatic responses. But again, 2 weeks is about our cutoff to say, all right, not everyone changes straight away or within the first couple of sessions, but we need to be confident that something is changing at that 2-week mark. And if it's not, then the likelihood is that the neck isn't that big piece of the jigsaw puzzle. It may be connected, and we can see all the things that we think we should be able to change, but it's not changing. And so at that point, we need to have that, unfortunately, honest conversation. And our patients are pretty switched on, that they understand that not everything is going to work. But again, we're honest about that from the outset as well. So we really pride ourselves on following this process. And again, for the majority, it's great, but there are a few that we need to say, look, I think we need to stop. And then it is a matter of going back to their doctor or their neurologist and looking at other options.
Right. And you know what? You said unfortunately, but I actually think that's quite a fortunate thing. It's not common practice for a specialist to say, we've reached that point that you need to seek other channels. So I actually think that that's a great positive, in that, you're not just pushing forward, still knowing that this may or may not help you down the line.
Yeah, and it's really core to what we do, in that, we understand what we can do, but we also understand what we can't, and where we need help. And, so I read a lot more broadly about migraine. I understand a lot about the role of nutrition, but I'm not a nutritionist. I'm not a dietitian. I understand some of the psychology, but I'm not going to start counseling anybody. So, but I can understand enough to know when someone might need professional help in that area. So we, as you mentioned, we sort of, even though it's not a physically located team, we do picture ourselves as part of that broader team to try and draw in, where we can, other expertise to help people but again, know enough to know when people do need that sort of help.
Excellent, excellent. So one of the things your team does is you aim for patients to become self-managed. Can you just tell us a bit about what that actually means?
Yeah, exactly. So we're not after clients for life. We want people to be able to manage this themselves, and that extends beyond what we do. You know, as you would know, there's being a migraine sufferer or a person with migraine, it's a life event. You've got to manage so many different things to try and, so this is not news to anybody listening. But again, we want people to be able to manage their own neck. And so from fairly early on, we mentioned that sort of 2-week block of the initial treatment. We're actually going through a lot of education, and we're about to sort of talk about some of that now, but also a stretch in particular that helps to control this little fault in the top of the neck and can be quite effective at actually helping to sort of shut down an episode when it's starting.
Oh, wow.
If they continue to start. So we're very big on transitioning people to controlling this themselves, and that typically, our treatment average is around 7 to 8 sessions. So we have the assessment, then we've sort of got 4 sessions in that initial block, and then we're usually tapering down to self-management pretty quickly. Right,
that's amazing. Excellent. So we're going to talk now about that shoulder neck situation that we have going on with migraine. So it's a two-way street. It can be a trigger for migraine attacks, but it can also be a symptom of migraine attacks. Can you talk a little bit about that?
Yes, I can. And as you say, it can be very confusing. I get confused listening to other people describe it at times, and I think depending on which way you're coming at it from. So what we need to understand is that there's a difference between the symptoms that you feel in your neck and the problems that you have in your neck. Mm-hmm. And the neck can be a symptom of the migraine. So about 30% of the people we treat don't have any neck symptoms at all, but they still have the same fault in their neck.
Right, okay.
About another 30% would report maybe a little bit of pressure under the base of the skull, but nothing they would necessarily call pain. But often they'll actually describe their head as feeling heavy. My head, I feel like I need to hold it up. My head's too heavy for my shoulders. Mm-hmm.
Yes, that's a common complaint in our chat group.
Yeah, exactly. And it's no different to, your head isn't too heavy or to be in your lap, but just like the light is too strong, but really, it's not, but it feels too strong, or the sound is too loud, or that smell is really noxious. So again, we have this sensory overload, and part of what can be amplified through that are the inputs from the neck as well. So that's where the usual sort of bash and crash, getting there and loosen everything up can be quite, it's a bit of a double-edged sword, because you're really dealing with sensitivity, and people say, well, it feels stiff here, so it must be stiff, so let's jump in and stretch it. Whereas in fact, you're actually overstimulating even more, and potentially, this is where some people may have a migraine episode or an attack triggered with.
Right.
So if we have a look at, as you said, it is a bit of a two-way street. We've got two sort of groups of nerves converging. So yeah, describing the connections between the nerves coming in from the neck and the nerves coming in from the head and the face as a two-way street is actually quite a good way of sort of picturing this. Now, this will be a fairly brief description. So if the viewers are interested in a more detailed understanding of how this works, there are videos on our YouTube channel. So what we have pictured here in blue, obviously, is what we call sagittal section. So it's sort of cut down the middle, and we're looking in from the side. And we have the structure in pink there is called the brainstem, and coming out of the middle of the brainstem there, we have the trigeminal nerve, which branches into 3, one going down into your jaw, one going up into the upper jaw, and one coming up, which actually comes out of the eye socket and stretches all the way back to about here. So the back part of the head, the main nerve going up there is actually a branch of C2. So it's sort of coming up this way with other branches sort of branching off like this. Now, between these two systems, this is the main sensory nerve for the head and the face. So it's not the special senses, so not sight, smell, taste, and hearing. They've got their own special nerve supplies, but this is touch, temperature, pain, all of these sort of what we call somatic senses. So it's the feeling of a dry eye, it's the feeling of a toothache, and it's the feeling of something touching your head. So let's use that as an example to understand how this system would work normally, and then we'll have a look at what happens with a headache. So let's say something touches the side of your head here. The little nerve endings in the skin are going to sense that input and send that signal through this top branch all the way back in through the trunk into the brainstem, and now it's actually heading downwards, going down into this lower part of the brainstem where it mixes with these cervical nerves in what we call the trigeminocervical complex. So that black structure is the trigeminocervical complex, and I'm going to expand on that on the right. So coming back to this little nerve that started in the skin in our temple, here it comes. So this nerve ending literally starts in the skin here, comes back through this trigeminal system, and then arrives in this trigeminocervical complex, and that's where it ends. Once that signal arrives in the trigeminocervical complex, it attaches to a relay nerve. So that relay nerve will send the signal. If we look back to the diagram on the left, it's going to come up and join another relay nerve in the thalamus, and then head off to the sensory cortex. So that's our basic circuit. So it starts here. One nerve will carry that back into the trigeminocervical complex. A second nerve will then carry that up to the thalamus, and then a third up to the cortex. So now let's bring the nerves from the neck into it. So let's say something touches the back of your head here, or a muscle in the neck starts to contract. That information is relayed on the same second order nerve. And in fact, these receive signals from up to 5 different nerve endings. So you can see now why there can be some miscommunication, and particularly if the signals that have come in from the head and face have been associated with pain, the brain will often start to interpret the signal coming up from this relay nerve as belonging to that pain, regardless of where it starts. So what is happening with a headache? Well, we know that these relay nerves are sending information to the brain that is being interpreted as pain in your head. But where is the original signal coming from? And this is where we test the neck to see whether the brain is actually getting confused. For example, if I push on your neck at C2, does that activate this relay nerve, sending a signal up to your brain? But your brain, when it looks at that to try and understand what it is, actually interprets it as coming from your temple. So this is what we refer to as reproduction of familiar head pain. When we push on your neck and see that your brain's actually misunderstanding that signal and interpreting it as coming from where you regularly feel your headache. So as we're holding this pressure, we then want to see that this signal is actually easing off and that your brain is then focused on your neck. In other words, your brain says, no, that's not it. I think the signal is actually coming from over here.
Okay, so next let's discuss those really difficult symptoms. So nausea, vomiting, vestibular symptoms that are associated with several subtypes of migraine. So how do they relate to what we've just been talking about?
Yeah, so one way to sort of picture this is that that trigeminocervical complex that we're just talking about is really about pain. That's about headache. And there are multiple connections here, but one of the assumptions, particularly with something like nausea, is that that's just sort of the natural outcome of having a lot of pain. And in some cases, it certainly can be, but we see people that have really intense headaches, and the example here might be something like cluster headache, where they have, sort of the most extreme pain that we're aware of, but actually only quite a small percentage of those, it's sort of around 20% or even less, have nausea and vomiting. So the nausea isn't just a natural consequence of having a lot of pain, but it's actually a separate area in the brainstem that's lighting up. So the trigeminal complex connects into it, but actually the strongest inputs into that are the muscles in the neck and the vagus nerve that's actually returning from the stomach. So we'll have a little bit of a look back in at the picture of the brainstem there, and just see where nausea sits, but also where the dizziness stuff sort of sits.
Excellent. Let's get into that.
So the trigeminocervical complex is very much about the feelings associated with a headache. So this might be throbbing, stabbing, pounding, pressure, these sorts of things. The key to understanding how nausea and dizziness tie into this is really understanding that they're dealt with by separate systems. So we've zoomed up on our brainstem here. And again, this is a very brief description, but here we have, again, our trigeminocervical complex. So this track is really dealing with headache. There's an area in here called the solitary nucleus, which is dealing with nausea, but also taste and smell. And there are parts of it that help control things like blood pressure. Dizziness and vertigo is actually being dealt with by the vestibular complex, which is sitting in here. So these are quite separate systems. The key to linking these together actually doesn't come from the trigeminocervical complex, but more directly comes from the small muscles under the base of the skull, we call the suboccipital triangle. So here is our suboccipital triangle. And these suboccipital muscles in the top of your neck are packed full of sensory units we call muscle spindles. And to give you some sense, obliquus capitis inferior, which is running this way, has 250 muscle spindles per gram of tissue. Now, the next highest in the body are small muscles that sit at the front of your spine, which have 50. The muscles in your legs have 1. So these are very richly packed with muscle spindles or sensory units. So here we have our little muscle spindle input coming in through C1 and heading to what we call the intermediate nucleus to send most of that information into your vestibular complex. Some of it will go into your cerebellum to help coordinate movement, and some of it is even heading into the solitary nucleus to help you control blood pressure. The solitary nucleus is also involved in sensing feedback from the vagus nerve, and some of this information gets misinterpreted as nausea. So you can see that any disturbance of the muscles under the base of the skull can potentially lead to loss of balance, can lead to dizziness, can lead to vertigo, can lead to nausea, but also can lead to funny taste and funny smells.
So let's talk about you and your team and the research projects that you've been involved in including the brainstem sensitization. Can you tell us a little bit about that, and can we talk about any research projects that you have in the works at the moment?
Yeah, definitely. So we started collaborating with the University of South Australia and the Watson Headache Institute as clinical researchers in 2019. Really bad time to try and get anything done, leading into 2020 when it was quite difficult to even see patients. Mm-hmm. But we managed to, along with a number of other clinics around Australia, we managed to get through a multi-centre case series, and that was on migraine with aura. And that's actually been submitted for peer review, so that one's finished. But individually, the clinics sort of took on another case study, but something that was a little bit sort of left of field, and so I did vestibular migraine. So we had 3 consecutive patients that were prospectively selected. So before we even knew how they were going to go, they were sort of nominated to be part of this case series. Mm-hmm. And that's gone really well. So we've just finished that. We're in the sort of dying stages, if you like, of the final draft, and that'll be submitted for publication soon. So
fantastic.
And there's a little bit of caution with, we had great response with all 3, but it is a case series, so there's no controls in it. So it's really just a bit of a first step to say, we can get some amazing results. We saw the 3 patients, their migraine attack days over a 28-day period went from 6, 16, and 7 to 0, and that was over a 6-month follow-up period.
Right.
But more importantly, that's important, but they all had quite significant interictal symptoms, so symptoms in between their migraine attacks. Mm-hmm. And that's sort of reflective of about 50% of vestibular, or people with vestibular migraine. And so their symptom-free days increased. So we had 0 increasing to 11. We had someone with 4 symptom-free days increasing to 17, and the last one went from 0 to 25. And again, that's on a 28-day period.
Gosh, that's pretty incredible. So
again, it's not a miracle cure. They've still got symptoms. In some cases, maybe a mild headache or maybe a little bit of dizziness, and often that's reflective of, particularly with the dizziness stuff, they usually do have very mild vestibular issues, not enough to be diagnosed with BPPV or Meniere's, but they usually do have a mild disruption of vestibular function and of the motion sickness. But one of the people we're actually talking to at the moment in terms of future research, Dr. Jessica Vikovich, one of her papers 10 years ago found that they have the similar amount of dysfunction, but they perceive it more intently. So again, this right. of this sensory system that sort of grabs things and amplifies it. And so I was very excited about that, because that's where I think we can actually have quite an impact. Is, again, we're not changing their function so much, but changing how overexcited or overstimulated that brainstem is, and not these what are often quite minor problems. So yeah, so that's sort of in the pipe works, if you like. So we're having discussions about what sort of outcome measures we might be able to use and looking at the next stage there. And the other one that we're starting is a collaboration with Associate Professor Alan Pearce, who's at Neurosports Labs here in Melbourne. He's an adjunct professor at La Trobe University, but a private researcher as well, and he's an expert in concussion. So we're actually and you know, persistent post-concussion symptoms almost identical to migraine, you know, and we see this in persistent whiplash associated disorder, and actually that's sort of where Dean started all the way back in the early 90s, was seeing these people that had quite obvious neck trauma with a whiplash, that had no history of headaches or migraines, but all of a sudden presenting with what quite clearly looked to be migraines. So that's what really got me into this in the first place.
That's some exciting stuff.
It is. It keeps me busy. But you know, as I say, you know, the biggest frustration in the last couple of years has actually just been obviously COVID, and I'm you know, not alone there, but just trying to, you know, coordinate with researchers that are in South Australia and trying to sort of get all that done. And everyone's sort of changing circumstances, but we're nearly there, and looking forward to the next steps for sure. Well,
we wish you all the best with that.
Thank you.
We're excited to see what comes of it. So let's end on, what is your top tip for someone thinking about adding a physiotherapist or someone like yourself to their care team? What would be your best tip?
Please do. I think we have a really important role to play, and particularly early in management. You know, we see ourselves as part of that team. It's not a miracle cure, but we can see results very quickly. And I think what I get frustrated with, and you know, I share my patients' frustration, is when, you know, they've been referred to the neurologist can't see them for 2 or 3 months, and then they're going on to potentially a preventive medication which may not work for another 3 months, or potentially for the second round. So, and that's fine. You know, we're you know, symptom suppression is really important. You know, a lot of people I treat would not be able to even come and see me if they weren't taking some form of medication to help them function. But we would like to jump into that gap where they're waiting and say, all right, well, great, you've got your appointment 2 or 3 months down the track, but let's see if we can do something in the next 2 to 3 to 6 weeks, once we sort of tail off to self-management, that might change this. And again, in some cases they may not need medication, but maybe it's half the problem, and maybe that then changes what the neurologist might then need to do, if they have to do anything. So again, it's really about looking at attacking this from all angles and seeing whether there's something there we can change. So if people are looking for, there are clinics all around Australia that are doing this. You can contact Watson Headache Institute if you're in a different state, or you can contact us here in Melbourne. But the real key is to find a certified Watson headache practitioner. And so that means they've gone through a process that includes an examination of the techniques and their knowledge. But also one that's still following those principles. So, it's important that we are honest about what we're looking for in that initial assessment, that we're sort of ticking those 3 boxes. Is there a problem? Can we change it? And is it relevant? But also that we're still expecting, we set a pretty high bar, but can we change it within that sort of 2-week period? Is there a significant change? Now, that doesn't mean you're cured or that we're done in 2 weeks, but for us to consider any further treatment, we need to both be happy, us and the patient, that there's a shift there, that we're actually improving the condition. And again, as we were saying before, to be honest about it if it's not, and not just wheeling on to, right, well, let's do some dry needling and some massage and some other things. At that point, we're not doing Watson headache approach. We're hoping that we might be able to do something.
You've raised really great points there, I think.
Yeah, and whether that's someone looking for someone like us on their team, or even just a patient seeing a practitioner, it's important that you understand, and not everyone is a certified practitioner. They may have just done the first couple of courses, and again, that's fine, but you need to understand what the expectations are, and what you're actually looking for. And you know, both parties need to be accounted for that.
For sure, for sure. And I think you touched on an important point there, that it's not a miracle cure, you know, and I think that's a really strong point to make, but that it is such a vital step in possibly reducing some of the most horrendous symptoms for people.
Yeah, and I think what, you know, in setting those expectations, we often don't actually do a lot of treatment. And you know, one of the things that gets me excited when I'm talking to a patient on the phone before booking them is when they say, I don't let anyone touch my neck, because every time they do, they will trigger vertigo or they'll trigger a migraine.
Mm-hmm.
Now, they're often scared about that. I think brilliant, absolutely brilliant, because it tells us it's part of the problem, and you just need the right technique. You need something that's not just about bashing and crashing and loosening everything up, but something that's actually going to deal with the sensitivity. And experience matters, you know, and I'm not going to sit here and say I never aggravate anybody, but we, you know, it is a delicate system, but I do it less and less. And, you know, it's about learning, and it's about understanding what the dynamics are and what we can do and what we can't. And again, when we might need to reach for help, but when we need to shift. And again, that there's a lot of experience that goes into understanding what is on face value seemingly a very simple technique, but it is a very dynamic area that we're working with.
Yes, absolutely. It's such a complex system that you're working with as well. So excellent. Well, thank you for chatting with us today. We appreciate your time.
Hopefully everyone found it interesting.
I'm sure they did. I know I did. Thank you so much.
Thanks, Sarah.
Thanks.